Open, outspoken, it's ophthalmology off the grid, an honest look at controversial topics in the field. I'm Blake Williamson. Hello, and thank you for tuning in to another episode of Ophthalmology Off the Grid. I'm Blake Williamson. Today, my co-host, Dr. Gary Wörtz, and I have the pleasure of speaking to our friends, Dr. Erik Mertens from Belgium, and also Dr. Gregory Parkhurst from Texas. We're talking about the excitement surrounding the EVO Visian ICL, which has recently received FDA approval for the correction of myopia and myopia with astigmatism. Dr. Mertens can share valuable international perspectives based on his experience of using this lens for the past several years, and Dr. Parkhurst provides insights into what he learned from the clinical trials. If you're looking for an opportunity to learn more about implantable Collamer lenses, these guests are amongst the best of the best surgeons you can learn from. Let's listen in.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Welcome to another episode of Ophthalmology Off the Grid. We are your host, Blake Williamson, and the man, the myth, the legend, Gary Wörtz in the house. Gary, what's going on, man? How are you?
Man, I'm really good, Blake. Today is such an exciting episode. I cannot wait to get started. We've got Dr. Erik Mertens coming to us live from Europe and Dr. Greg Parkhurst. And today we're talking about, I think, one of the most exciting launches in ophthalmology in a long time. We're talking about EVO. So, Blake, what are you excited about EVO first? And then we'll kind of get started with some historical and experience facts from the guys.
Yeah, well, first I'm excited about the t-shirt you're wearing. People are listening to this on a podcast, so they can't see the video, but I love that you're repping the Hot Cotton Radio. Shout out Hot Cotton Radio. Also good coming off that Millennial Eye meeting. I loved hanging out with you and seeing everybody, especially all the young surgeons. And a lot of people were talking about EVO. And, my thing is that, if you're going to learn how to do something, you need to learn from the best, people who do the most and people who have the most experience. And that's why I love that you selected these two guests today, and we're going to learn so much from them, both on an international perspective, which has been out for 10 years or something like that. Over 1 million implants or close to it implanted, and then also here nationally we have Greg Parkhurst, who everyone knows, and it was part of the trials and everything. So I'm excited to hear from them, and I think that what excites me most for everybody listening to this podcast is now is the time to get up off your butt and get started with ICL. If you have not done an ICL, but you do LASIK and you do multifocal lenses, you need to ask yourself why that is, and you need to address that problem. And I think that these two cats are going to tell us how to figure that out.
Absolutely. I have a little bit of experience with ICL in the past, and some of the barriers I bumped up against were, who's the right patient? What's the right? Is it just for the high myopes? In our practice, we sort of just selected those -10 and above people who couldn't really have LASIK based on the ablation depth, et cetera. And it was really pigeonholed into a small category of real high myopes. We had to do the LPIs. It was expensive, and it just filtered out a lot of people. But I want to start with Erik. And Erik, it seems like EVO is really changing the way people are thinking about phakic IOLs in the realm of refractive surgery and where they put it in, into their armamentarium. So a few facts just to kind of think about. In 2016, I think when EVO was launched, ICL was about 2% of every refractive procedure. 2019, it was 6%. And now at the end of 2021, it was 9% of all global refractive procedures in the world were EVO. So Erik, will you just walk us through the transition that you had when you were going from the Visian ICL to EVO? How did it change your conversation? And how have you enjoyed using it over the past number of years?
Well, first of all, thanks guys for having me and I can share my experience with you at the ICL. And I'm very thrilled for my US surgeons, US colleagues, that they can finally use the EVO Visian ICL. So I went through a transition, and when I was doing the ICL, first my cutoff point was -8 and above. Then I went down to -6 and above. And from the EVO Visian ICL onwards, it dropped dramatically in the first 2 years after the introduction in Europe. It was introduced in 2011. And actually, every myope now is a candidate for ICL. I've done -1s with the ICL. Of course, we have to discuss whether refractive laser surgery is also an option. But you can do any kind of myopia with the EVO Visian ICL, because, as you pointed out, you don't have to do any extra work, no laser PI or surgical iridectomy, which makes it much easier. No extra visits for the patient to come into your office, no extra burden. You put in pilocarpine for the yak iridotomy, which is bothersome and so on, and also cost effective, makes a huge difference. And on top of that, once in a while, we got some pressure spikes with the previous ICL, and we got emergency calls that there was an angle closure glaucoma. I've never seen a pressure spike or angle closure glaucoma since I've been using the EVO Visian ICL. So in safety, terms of safety, huge difference. And by 2011 until now, I've been doing percentage-wise of my total volume more and more ICLs, and now more than 80% of my total volume is ICL, which is of course a little bit atypical, but that's the way it is.
Blake, how does that strike you? 80%. Can you imagine doing 80% of your refractive procedures ICL? I think that speaks volumes to how EVO really changed the game for you in your practice. I think in the US, it's going to be the diopter powers. I think it's going to be from -3 to -16 in terms of the dioptric powers, and then 1 to 4 diopters in terms of toric by half diopter increments. So I don't think we'll be able to get to go as low as you can go in Europe right now.
Yeah. I tell you, Gary. What strikes me though, Gary, was what he just said. He would go up to like a -1. So basically, like if he can do it at ICL, he's doing that. And so I think what strikes me the most about that is I believe that residents coming out of residency in this country have more tools, and have more comfort with doing an ICL than they would LASIK. Because they're inside the eye, they're already in the anterior chamber fooling around, they're doing MIG surgery, they're doing lenses, right? They're not making the flap and lifting flaps. So even though we all know LASIK is very straightforward, to skilled surgeons, like I think that residents actually the ICL is sort of more in their wheelhouse right out of school than even LASIK is if they didn't do any LASIK in residency. So that's interesting that especially if you don't have to do PIs and you're not worried about glare from the PI and all that stuff.
Yeah, I'll be honest. I found it a little bit awkward starting LASIK. I started with microkeratomes, and it's like everything's great until it's not great, right? Until you have a free cap and you're looking for the cap inside of the, mangled up inside of the microkeratome, or and you're trying to put that back on and line up the marks. You trust the machine, but the machines don't always operate 100%. So even doing automated surgery like LASIK, you still have to, you're putting a lot of trust in that machine. Whereas when you're doing anterior chamber incisional surgery, I feel like I've got more control when I'm doing cataract surgery because everything is in my hands. Greg, what are your thoughts on this? Obviously, you were part of the US FDA trial. You're one of the rare surgeons in the US who've gotten a sneak peek at this. What are your thoughts on what Erik said in terms of his transition from the Visian ICL to EVO? And how do you see this fitting into your practice going forward?
Yeah, well, I'm really excited about it. I think that we're going to be doing even more ICLs now that we have, the central port in it, the fenestration. Really because it makes it a lot easier for the patient. We used to tell patients, even last week when we were still doing some LPIs, okay, this is the worst part. So, once you get through the LPI part, the actual procedure itself, piece of cake, the hard part's the PI. And it's the laser treatment itself, but not to mention, sometimes more than an hour waiting for pilocarpine to take effect. The headache, the brow ache. Sometimes I've had patients get nausea and even vomit from pilocarpine. And, in the world of refractive surgery, we're trying to make this a great experience, not only trying to nail our outcomes, but we also want this to be an easy experience for patients. And so I think the EVO is really going to accomplish that.
Yeah, I actually have had a couple of patients who I do all of the, we call non-refractive lasers in our practice. So I do all the LPIs, SLTs, and YAGs. My partner actually ends up doing the bulk of the ICLs right now. But so I had the unfortunate task of doing the LPIs on the patients that he was going to mainly do ICL. And I've had a number of them, not a ton, but a number of them actually pass out in the lane because I would do 2 LPIs per eye. So we end up doing 4 LPIs. And it's just not a fun part of the procedure. So I'm super excited that we can get away from the LPIs. And also from a timing standpoint, we can do this like tomorrow. If someone's ready to sign up for ICL, it's not like, okay, we've got to schedule the LPI, we've got to schedule a follow-up, then we've got to get you in for surgery. And then, Erik, are you doing bilateral, generally a bilateral sequential ICL on the same day? Or are you separating these procedures out?
I do bilateral sequential. Even before the EVO, I did bilateral sequential. Because of, when you do corneal refractive surgery, you also do both eyes at the same time. Of course, we change our instruments, different kind of sets of instruments, different batch numbers for the methylcellulose and so on, different gloves and so on. So actually, endophthalmitis is not a big issue with ICL. There has been a very nice paper published many years ago about 18,000 eyes, and there were only three of them had endophthalmitis. And 2 out of the 3 where the outcome is known, they recovered 20/20 vision with the appropriate antibiotic treatment. Because of course you still have that barrier between the anterior and the posterior segment because the zonules are intact, of course, the lens is there. So even then, when you get an endophthalmitis, don't panic. In those cases, you can get a very good visual recovery with your appropriate treatment.
Greg, what are you doing? Are you doing sequential or?
Yes, we've been doing sequential, bilateral same-day sequential surgery for years, even going back to, over 10 years ago when I was doing these in the military. We had a similar protocol, and like Erik said, you simulate 2 separate trips to the operating room by having 2 completely separate sets. We actually have 2 cabinets. We have a right eye cabinet and a left eye cabinet, and every medication is a separate lot number from the manufacturer in the left eye cabinet and vice versa. So there's, even in the extremely unlikely chance there's some sort of contaminated solution, it's only going to touch one eye.
Yeah, and for us, we do it a little differently. Dad still does it. He's always done it a week apart. He'll do one eye, and then the following week he does the other eye. Not because of endophthalmitis, but just because of sizing. We know that the biggest issue with ICL is sizing and what do you use. Everyone uses different things, different machines, different algorithms, and so it's hard to pick one device. Even though I think there is some consensus on a few boxes out there do a great job. But his thing is if he has a pressure spike or it's too big on the first eye, then he sizes down. So my thing is I have the luxury of having 2 surgery days back to back, Tuesday, Wednesday. So what I do is don't make them make the whole week because that's kind of miserable in between eyes. It's like having a roller skate on one foot and a cowboy boot on the other. But I will do a Tuesday, Wednesday deal, right? So I'll do Tuesday and then see them the very next day. And if they're rocking and rolling, which 9 times out of 10 they are, then fine. If they do have a little pressure issue, maybe we push it a week. And so for those listening to this who may not want to jump full force into bilateral sequential, just know that there are other ways to do it. If you can do it back to back, that'd be great. But certainly within a week.
Yeah, I think that's a good point, Blake. I think with this with EVO, we're gonna be seeing this more and more that we're doing bilateral sequential. Greg, I want to know from your standpoint. You've done the clinical trial, and then we'll flip to Erik. Where do you feel like the sweet spot is for EVO? A lot of times for me, the conversation of ICL was like, you can't have LASIK, so what else can you have? Like maybe they have some sort of form-produced keratoconus. We think excimer ablation is not going to be a good idea. Maybe they don't have the cornea is too thin, Ks are too flat. Maybe even Avogen, their Avogen score is high, and you're worried about some risk there. Where do you feel like now, instead of just saying, okay, you could have LASIK or you could have ICL, where do you see the sweet spot for ICL fitting into your practice?
Well, when I talk to surgeons who are just getting started with ICL, that's usually where I think is most natural to start is in those non-laser candidates. That's kind of the low-hanging fruit. Someone who's a super high myope, we're definitely not going to do a laser treatment on a -15. Is there another option? Well, contact lenses, sure aren't great. Glasses are 2 inches thick. That's not a good option. So, is there is there a vision option for somebody that's in this kind of dire straits of super high myopia? And that's like the lowest hanging fruit to start. Next from there, I would say, some of the things you just mentioned, Gary, but, people with thin corneas, maybe there's a little inferior steepening. You're wondering, like, even if I did a, -5 ablation on this cornea, is there any chance that it could go on to develop ectasia? So those kind of borderline corneas where you're thinking, I don't know about how I feel about laser here, ICL is a great option. And we've published outcomes in kind of abnormal cornea cases, and they're excellent. Kind of like Erik said, though, once you start using it in those environments, it's natural that the power you start using goes down. Because what we've seen for years, I remember this again, even going back to my military days over 10 years ago, these were some of our happiest patients, just subjectively. They come in and it's like people are very happy. And so you find more and more reasons to start considering offering an ICL. So today, the way we present it is we say to all of our patients, hey, when you come in, we're going to do some scans. We're going to measure your eyes and let you know which procedures you're eligible for. Some of them are laser treatments. Some of them involve lens implant approaches, and we'll let you know, what you qualify for and answer any questions that you have. And just by presenting that as an option to everybody, it's interesting. There's a lot of people out there that like the idea of a removable, reversible technology. They like the idea of, leaving their cornea, fully intact. Others, like, they hear lens implant and they get ultra squeamish and they're like, no, this is not for me. But there's quite a large number of patients out there that are intrigued by this option. They often haven't heard about it before. They ask more questions, and then you can go down the path of informed consent. Pick the procedure that they're most comfortable with.
In terms of cost, and then I'll get you to you, Erik. Do you try to price it competitively with LASIK? Is it a little bit more expensive just because of the OR supplies and facility fee? Where are you? I mean, you don't have to say where you're pricing it at, but like generally speaking, is it about the same price or 20% more, 30% more than LASIK?
We try to keep it within about $1,000 per eye of our LASIK price, so that it's not this like huge leap. One thing that's the thing that's required to be able to offer price points like that is you can't be doing it in a hospital, because oftentimes, like, if you're trying to do it in a hospital, it's going to cost like $15,000 or something. It's a crazy number. Like, people aren't going to do that. If you have your own ASC, or if you have even an IOR scenario, you can keep the price point on the facility more realistic for patients.
Right. Erik, you talked about the fact that your practice has grown to 80% of your practice is now EVO, and you're offering it down to -1. How does that conversation go? You clearly have the skill set and the tools and the technology in your office to offer the latest and greatest technology in the world to your patients, and you're choosing, and your patients are choosing EVO. But where do you see the sweet spot? Like, when a patient comes in, is it a -3? Is it a -5? Or is it other factors you're considering? Because you consider EVO and LASIK kind of parallel technologies, and the other factors are driving the decision.
Well, of course, it's a process, but in the end, what we do now, we send an information brochure to the patient by email, and there ICL is positioned right next to LASIK and right next to SMILE. But it's a premium procedure because of, and already Greg talked about it, it's reversible, it's removable, high quality of vision, no issues with dry eyes, and et cetera, et cetera. Night vision quality is very good. The paper was published by Greg, by the way, many years ago, the comparison of both laser refractive surgery and ICL. So, and now patients come in, and I always say, okay, let's do the test first. We have the laser options, you have the flap option, you have the lenticular extraction option, or you have the intraocular lens option. Let's do all the tests first, and let's then discuss the pros and the cons. So my patient coordinator is doing that, and they're all very well trained in that. And most of the patients, they feel like that the ICL is in their case the best option, because they're long-time contact lens wearers, so they have dry eyes, or they have night vision issues. Or, as you said, as you already mentioned, I see in a lot of discussion groups that would you do LASIK or PRK on this eye, because I see a little bit of steepening there. So, like, come on, guys, why bother? Just put in an ICL and don't have to bother about the cornea. So all of these things, of course, I mean, it's easy for me to speak because I have already 10 years of experience with the EVO. But this will continue to develop in the US as well. So you'll see in 5 years down the road that people will start thinking like I think already, like, okay, there is a problematic cornea, if you have dry eyes, just put in an ICL and you can sleep well at night. That's easy.
Yeah, I think that people are going to start to gravitate down. I mean, I would say that most people I talk to who aren't putting in a ton of them, but are comfortable with it, they're still doing LASIK for, -5, -6s, -7s. Usually it's that -9 and up that they tend to go there. But I think you're going to see that creep down to closer to 6 or 7. That's what I think. I mean, at the end of the day, I still enjoy lifting a flap and doing a 4 diopter ablation. It's no big deal. But I think I'm going to start going down to closer to 7, I would think, in a perfect LASIK candidate. Greg, is that how you feel? I mean, do you have a number cut off if they're a perfect LASIK candidate, or a perfect ICL? You could do either. I mean, are you still doing 5 and 6 diopter ablations, or?
Yes, I'm still doing 5 and 6 diopter ablations. But I would say, kind of that range you're talking about right now, up in around 7 or 8 is when I really start to lean more ICL and make the recommendation. Now, if a patient pushes back and they're like, no, I really just don't want this implant, will you please do a -8 LASIK on me? I will still offer that, provided their cornea is sufficiently thick and sufficiently healthy. But I do make the recommendation about the reasons why I think ICL is better at that range. They still get to make the choice on their own.
And how do y'all recommend that people get started with this? Because I'll tell you, my personal journey was like when I first started, 6 years ago, my father was doing all the ICLs. I was like, okay, cool, I'll just send those people to him. And I'll be honest, like when I was like, gosh, I'm sure it's easy and he makes it look easy and I can watch y'all's videos. But if I do something wrong, all of a sudden I'm doing a cataract surgery on a 22-year-old -15 patient, right? And so it was that trepidation that I was kind of like, well, I have someone next door that can do it, so why not just send it to him, right? But a lot of people don't have that person next door, so like they have to decide to do it. So I started doing them onesie twosies and getting more and more comfortable. And after about 10 or so, I was like, oh, I can do this. This is pretty comfortable. So how would y'all recommend young surgeons listening to this that want to get started? Is it wet labs? I mean, do you just go straight in and just put it in the first eye and hope for the best? I mean, what do you do?
I think there's an initiation course run by STAAR Surgical, which is very good that you take it. And once you have the background, the scientific background, start with high myopes, deep anterior chambers, so a lot of, and have a rep be in your OR. Because in the beginning, when I did ICL, it took me 45 minutes for one eye. And I had problems loading the ICL. And then one of the reps of STAAR came in. He taught me exactly how to load the lens, because this is one of the most important things in ICL surgery. Load the ICL perfectly. Take your time. This is a golden advice I will give to everybody. Load your ICL perfectly, because when you deliver the ICL in the eye and it is turning around or even flipping around, then you're not in big trouble, but you have to take it out and load it again and so on. So, but when you load the ICL properly, it will deliver nice and fine in a flat fashion, and it's easy to put it behind the iris. Second thing is, when you inject the ICL, do it slowly. That's the only part of the surgery you have to do very slow, so that you make sure that the ICL is delivered in the right plane. So these are my 2 tips for the ICL beginners.
I agree with all those points, Erik. And I would say, in addition to taking those courses, is also talk to some surgeons that are experienced with the ICL, because, you just gave a couple of great surgical tips there, and there are others, I could list a couple. Number one, I would say, don't overfill the anterior chamber with too much OVD. I think that's an instinct that we have as anterior segment surgeons, especially resident coming out. I can imagine, you want to just push everything out of the way. But an overinflated, puffer fish anterior chamber is not the type of environment that aids in ICL surgery. So you actually want to let some of that viscoelastic out after you've made the incision. And there's some other little tips just around, like, where's your paracentesis? What direction is it pointing? How do you fashion that? Just little simple things that can make a difference. So I would encourage people to talk to other surgeons that have done a lot of these before they start doing a bunch.
Yeah, that's great advice. And Greg, I'd also like to know, from your standpoint, what nomogram are you using for sizing? I think you have one of your own, perhaps, that you've developed. To me, one of the biggest question marks is, how do I figure out the size? I think it's a little bit variable based on what device you're using and your experience. We talked just a little bit about how you go through the sizing of ICLs in terms of measurement and what one you order.
Sure. Yeah, I think it's a great question because I actually think this whole sizing conundrum is really where EVO is going to make a tremendous difference, because the fact is the EVO is going to be more forgiving and more tolerable to slightly undersized and slightly oversized ICLs that the prior versions did not. So the great news is you don't have to be as precise with sizing this lens than we have had to be in the past. But to answer your question around how do I size it, we've been using ultrasound biomicroscopy for many years. The particular device that I used, and actually a paper just came out published by Morshafar out of Hoops Center that looked at our nomogram that we developed on a retrospective analysis. But it's basically looking at things like the sulcus diameter, the shape and rise of the crystalline lens. A couple other measurements that we make in terms of picking the right size. We've since gone on to using the ArcScan device more recently. And there's a really nice nomogram that you can plug in online. It's called iclsizing.com, put up there by Dan Reinstein from the London Vision Clinic. And you can actually have a technician do the scan with this device. I still think the surgeon should do a lot of the caliper placement because there's some judgment around, where do you put the calipers and where do you get the numbers from? But you can plug that into an inline nomogram, and it's really interesting how effective that nomogram is at predicting what your vault will likely be postoperatively. So whereas in some of the prior nomograms, it would suggest like, okay, in this eye use a 12.6 and in that eye use a 13.2 size. In this newer nomogram, it actually tells you, well, if you use a 12.6, here's the likely vault you'll achieve. Whereas if you use a 13.2, you'll probably achieve this other vault. And so you can kind of make a decision as to whether it's a super deep chamber. You might prefer a little bit larger vault. If you're borderline on the chamber, you may want a smaller vault. So you can kind of prescribe which lens you want and what vault you want using that kind of sizing strategy.
I guess most people will just kind of would just size one down. Wouldn't you say, Eric, if you're kind of in between two? It's always, I've always learned that it's much easier to deal with a lower vault, especially if you have that center hole.
Well, exactly. And I have a series now of more than 30 eyes, which I'm following for 6+ years with a vault of less than 100 microns. And I haven't seen a single opacity in all of these crystalline lenses. So which means that this is very safe because of the aqueous is pushed between the crystalline lens and the ICL before it goes into the anterior chamber. So there is always a separation between the ICL and the crystalline lens. So that's one. Secondly, it's I use for a nomogram, it's based now, I used everything, white to white, UBM, whatever. And I'm using the last years, based on the anterior segment OCTs. And I started with the Nakamura formula. So whatever machine you're using, use the Nakamura 2 formula, which is published in the American Journal of Ophthalmology a couple of years ago, and start with that. I'm now using my own nomogram, which is based on my anterior segment OCTs, an MS39 from CSO, which is not FDA approved, but this is based on sclerospur to sclerospur, lens rise, the thickness of the crystalline lens, the cornea volume, and so on and so on. But this will be published hopefully at the end of this year, but we're still working because it's an AI-based nomogram, and we're getting there. So that is based on one single anterior segment OCT, but the Nakamura formula is very easy to use and already very, very predictable in its sizing. And as Greg pointed out, also the higher vault is also less problematic than the previous versions. But still, I don't like the high vaults above 1,000 microns because it can push the pupil a little bit open and so on. So I rather go down with my sizing, except of course for the toric ICL, because you don't want that toric ICL to rotate. That can be a little bit tricky then when the toric ICL, then you have to be wary that you do not undersize and maybe induce some rotation, late rotation, which you don't want in toric ICLs, of course.
Guys, thank you so much for taking time to give us a little bit of both the national and global perspectives on EVO. I'm super excited about this. This is a technology that I think is on the rise, definitely around the world and here in the US. We're going to see what happens, but I'm really excited about it. I've heard kind of off the, some rumors that pricing is going to stay neutral, maybe even a little bit down from the old model Vision ICL. I mean, we'll see if that's true or not, but that's sort of the word on the street that they're going to keep prices pretty much neutral, which will be great. And I just can't wait to get started with this and see the success and how we can help treat our patients.
Yeah, I think that I agree with all that. And I think that, there's even cooler stuff coming down the pike with the presbyopic implant as well, So I think that lens-based surgery and phakic surgery is here to stay. STAAR has really done a transformation over these past few years with new leadership, and it's been amazing to watch. So thank you, Erik. Thank you, Greg, for coming on and giving us your expertise. And thanks to our listeners for tuning in to another episode of Off the Grid. Thank you to Dr. Gary Wörtz, Erik Mertens, and Greg Parkhurst for joining this episode of Ophthalmology Off the Grid. And thank you to our listeners for tuning in. Until next time.